diagnosis of infected total knee arthroplasty. That will be the subject of my next talk. So first of all, before you think about an infection, I think it's important to get information about the risk factors. First of all, the host, as we all know, if patients are immune compromised, and think about the local environment. Secondly, if you classify it, think about whether there's a short duration or long duration. Probably that's the most easiest way of classifying whether the symptoms are there for a few weeks or longer duration. And probably the longer durations, those are more difficult to diagnose. So the history and clinical workup, sometimes it's very easy, but also in the long-standing low-grade infections, it might be more difficult. Most patients will claim that their knee has never been right, permanent pain both at rest and during the night, had wound healing problems or fever in the first post-op period of time. Think about whether they had prolonged antibiotic treatment after the primary surgery. Think about reoperations, prevent cultures which have been taken, and look for microorganism which has been cultured and the sensitivity of it. And of course, look at the knee itself, swelling, effusion, and soft tissue conditions. So when, and we know that from literature now, recent supplement by the Journal of Arthroplasty from these authors showed when is it considered to be a prosthetic joint infection, there are 2 major and 5 minor criteria. The major ones are fairly obvious. If you have 2 positive cultures with the same microorganism, after taking a look at it, it's positive. And of course, if you have a case like this, if there's a communication with the joint and there's a so-called mirror sign. It becomes more difficult if you look at the minor criteria, because we all know elevated CRP or ESI might be a minor criteria, elevated synovial fluid, white blood cell count, and of course the PMNs in the synovial fluid might be elevated. Positive histological analysis of the tissue, a single positive culture, and a change in the leukocyte esterase strip. If 3 or minor of these criteria are present, they think it's called an infection. So these are the references you can take a look at if you're interested in it, and I'll try to take you through some of the important steps. First, of course, the CRP and the ESR. What are the thresholds if you think about an infection? Probably the normal ESR of 30, CRP of 10. If they're both negative, the infection is extremely low, the chances of it. Remember that both of these parameters can be elevated in the acute post-op time during the first 6 weeks. Aspiration, I think every knee that's, let's say, probably infected needs to be aspirated. Unfortunately, you only get a single positive culture back. Remember that some of the literature shows that synovial fluid cultures fail to grow in about 30 to 50%. So it's not, let's say, 100% positive. So if you're still very, let's say, on the clinical part, thinking of an infection, so the suspicion is high, combine the aspiration with the biopsy, and then, of course, stop the antibiotics 2 weeks prior to the culture, and then culture it for 10 to 14 days. What about the threshold of the synovial fluid? If you send the aspirate, what we use now is the thresholds, as you see here, known from the knee, from the last study by Greg de la Valle, over 3,000 is probably the threshold. If you look at that, the PMNs should be percentage-wise over 80%, and if both of those cell counts and PMNs are over 3,000, over 80%, probably this is a high value in the diagnosis of an infection. Good to know that inflammatory arthroplasty, arthropathies do not impact both of these thresholds. Leukocyte esterase test is very commonly written about. We don't use it routinely. They say it's quick and cheap. Unfortunately, it's not sensitive if there's blood stain. They came up with another solution that you can use this mini centrifuge. We have no experience with it, but probably that will be a solution to take into account that this blood stain will leave you with a false negative outcome. What about nuclear imaging? We don't use it routinely, although there's substantial evidence that some of them are effective. Many different techniques. Most commonly used, I think, in infection is either the SPECT-CT or the leukocyte scan. But I think currently we have cheaper alternatives, so we don't use it routinely, and especially not if you look at an infection in the first post-op year, because you get false negative outcomes from the scans. It may be useful if it's normal, and it can be used to rule out infection of distant focus. So if you have a heterogeneous infection of a joint, you want to know whether there's an infection in the heart valve or somewhere else. What about gram stains? There's, I think, substantial literature telling you that this test accuracy is approximately 80%, which means that, unfortunately, so far we don't use it anymore. Then, of course, frozen section, so get histology. I think it's a good test to rule in, diagnose, but they are less reliable in ruling out, so we don't use it routinely. What about the future? There are some biomarkers which are discussed now. Currently, there is a paper on the synovial fluid alpha defensin, which probably together with the CRP test demonstrates a very high sensitivity and specificity. We don't have experience in our hospital with it, but probably the biomarker issue will be something to look at in the future. Sonication, it's just a process where you send the whole prosthesis out and look whether there's a low-grade effect. We have looked at it and presented it at the European Infection Society last September, and we looked at over 245 patients with both hip, knee and shoulders, and combined the sonication to 6 periprosthetic cultures, and unfortunately we found that there's no, let's say, it's not a useful indicator as a diagnostic tool. So there's still some argument about that, but I think some hospitals routinely use the sonication. We don't do it anymore. So in conclusion, start, as always, with any workup, with the history, a clinical situation and the risk factors. Always start with the ESR and CRP. Aspirate the joint. If you have no aspiration, so if you have a dry tap, use the biopsies. And if you are still have a high suspicion of infection, I think you need to combine aspirations with biopsies and look for culture, white blood cell count over 300 and PMNs over 80%. And this will probably give you, in most cases, an infected joint or not. And of course, there are future developments like the leukocyte esterase test strip, the biomarkers probably in the future, and there's a question mark behind the, let's say, standard or routinely use of sonication. We have stopped using it. Thank you very much.